Hi, my name is Carson Edwards. I'm a rising second year at Mercer School of Medicine on the Macon campus, and I have the pleasure of introducing Dr. Stephanie Dare Singleton today. Dr. Stephanie Singleton is a board-certified reproductive endocrinology and infertility specialist currently practicing gynecology at the Mercer Clinic in Putnam County, Georgia. She grew up in Georgia and has a long history with Mercer. She received a Bachelor of Science degree in biology at Presbyterian College before returning to Georgia, where she followed in her mother's footsteps and attained a Bachelor of Science degree in nursing at Georgia Baptist College of Nursing, now Mercer. She then attended Mercer University School of Medicine here in Macon, Georgia, and discovered that she enjoyed providing care to women and pursued her residency training in obstetrics and gynecology at the University of Tennessee and fellowship at the Jones Institute for Reproductive Medicine in Norfolk, Virginia, where IVF first began in the United States. Early in her career, she practiced in South Carolina and Atlanta, then returning to Charleston to open a solo practice of fertility, the Fertility Center of Charleston. She had offices in Mount Pleasant, South Carolina, as well as Savannah, Georgia, providing consultations, surgery, ovulation, induction, and intrauterine insemination, as well as in vitro fertilization. She most loved the relationship that she developed with couples while helping them through the hurdles of fertility treatment to achieve their ultimate goal of a family. She never got over the amazement of how the science could help them realize their dream of starting a family. After 7 years, she returned to Georgia for her family and sold her practice, which has continued to grow in the hands of the Piedmont Reproductive Endocrinology Group. She and her husband moved to Eatonton, Georgia, and she runs her family business, Silt Saver, a manufacturer of specialty erosion and sediment control products. While she has enjoyed the challenge of learning to lead in a new industry, she realized the need for gynecology in Eatonton, Georgia, and that there was a Mercer clinic located there. She felt like this was faith and has carved out time to provide gynecology services to the women of Putnam County. She says that she treasures her Tuesdays when she gets to work with the women of Putnam County to provide gynecology care, and is excited to be here today to talk about her first love, reproductive endocrinology and infertility treatment.
Thank you for having me today. I know it's an interesting combination to hear that I now run a company that manufactures erosion and sediment control products and do gynecology on Tuesdays. But I've really enjoyed the opportunity. You know, we're talking a lot today about the need for obstetrics in rural areas. And Eatonton's an interesting area because it's on Lake Oconee. It's still a rural area, although, there's a Ritz-Carlton there. And so it's a very interesting area, but it also lacked gynecology. And so not only are we in need of more obstetrics throughout the state, there are definitely areas that need gynecology. And, you might think, well, typically that's covered, can be covered by their family practice doctor or internal medicine doctor, and often it is, but often those people are not comfortable at doing pelvic exams or looking at that little, itchy area or, the other things that can sometimes come with gynecology. And so I would brag on Mercer for recognizing that. And I think there are two of us that actually offer gynecology at the rural clinics, so I'm happy to do that. Today I was asked to talk about fertility and how fertility fits into that teamwork. And I think it's interesting that many people think of us as reproductive endocrinologists and infertility specialists as kind of sitting out there on our own and being kind of an island out there beyond. We became OBGYNs, but then, we decided to go and, practice this specialty. And so we kind of sit out there and we're separate from the rest. But it's kind of like Dr. Sumner said, nobody accomplishes great things by themselves. And I think that is so much the case for us. We help these families to create these precious babies and to create families. But there's no way that we could do it on our own. And what we sometimes find is that it seems like we are the coordinators amidst so many other physicians and disciplines and types of medicine, because there's no way that we can take care of those patients by ourselves. There's no way that we can accomplish what we do by ourselves. And so it very much takes a team. So in trying to show you that today, I thought I would present some vignettes that just kind of demonstrate how we work with the other disciplines, the maternal fetal medicine specialists, the oncologists, urologists, counselors, number of specialists to kind of get through the process and create those families. So we'll start with Elizabeth. Elizabeth is a 33-year-old G4P0 female. She and her husband have been trying to have children for several years. Each time they finally conceive, they're on top of the world, and then they suffer another miscarriage. And her OBGYN then refers her to an REI. So, most people think of reproductive specialist as, synonymous with IVF or intrauterine insemination, and we actually treat a multitude of other problems. And one of those is recurrent pregnancy loss. I often tell people that REIs are with patients in the best of times and the worst of times. The best of times when you finally accomplish that pregnancy and you see that heartbeat on the ultrasound, it's the best thing ever. You feel great. The couple feels wonderful and they're on top of the world, but it is the worst day ever when they come back for that second scan and you don't see that heartbeat. Or it's someone who has suffered this recurrent pregnancy loss. And so treating a lot of different things. So a tearful Elizabeth presents to the REI. She's depressed and afraid to try to conceive again. And that's what we often run into. Nobody goes to see the reproductive specialist and is excited about it. Typically, they're coming to us after they have tried everything else and every herb and every practice and everything their grandmother and their cousin told them, and it has been ineffective. And so when they come to us for assistance, they are often very sad, very broken from all that they've been through. So the REI suggests a counselor and a recurrent pregnancy loss workup, and the rest of the team starts to get involved. So we'll kind of walk through that. About 40 to 60% of patients that present to the infertility specialist are suffering from depression and or anxiety. And so it is very, very common that we are going to at least suggest a counselor. You see everything from blaming themselves that they can't make this work, blaming their partner that this isn't working. I often thought that some of the easiest couples for me to treat were, in fact, my same-sex couples, because there was no blame. There was clearly a reason that they could not get pregnant, and that kind of took some of those emotional factors off the table. They were just so thankful to have someone that would help them. And they didn't have to deal with some of those other emotional aspects. But oftentimes, counselors are involved in treating these patients. If it's a recurrent pregnancy loss problem, we're often going to involve a geneticist, because we're also going to look at karyotypes. What are the reasons for recurrent pregnancy loss? They can be genetic, they can be anatomical, they can be chemical, they can be basic medicine. So looking at those karyotypes, looking for a normal 46XXXY, there are a number of abnormalities that can occur that can result in either abnormal pregnancies or lethal pregnancies. And so trying to figure out if either parent has one of those abnormalities that is contributing. And there again, having that counselor already on board, someone that they can talk to as they're going through this, is an abundance of help just to get through it. So a multitude of different abnormalities, the reciprocal translocations, Robertsonian translocations. And some of these, some patients will say, but we have one normal child. How could we have something wrong? And these issues often do not result in pregnancy loss every time, but do increase their risk of that. So involving a geneticist that has the time to sit down and really draw the charts and walk them through that is so helpful. The previous speaker spoke a lot about health issues before women conceive. And so we often find that when we start looking at either infertility or pregnancy loss, that they have some underlying medical disorders that we need to address to enhance their chances of achieving a healthy pregnancy and a continuing pregnancy. Enlisting the internal medicine specialist and the family practice specialist often at, controlling diabetes, looking at thyroid abnormalities, very common in middle-aged women, especially, finding hypothyroidism, having patients come in who are desperately seeking pregnancy and can be very, very sad or even very mad at the fertility specialist because we won't proceed with treatment because their hemoglobin A1C is at a ridiculous level, and making sure that we can check to make sure that they are first healthy to produce a continuing pregnancy before we get started with any other treatments. And there again, enlisting the help of internal medicine and family practice to do that. Then we would look at the anatomical issues that can contribute to pregnancy loss. And sometimes this involves a radiologist, honestly. Sometimes it doesn't with fertility now, because oftentimes in our clinics, we will have our own C-arms, so we can assess that oftentimes without a radiologist. If you are in a hospital setting, in a university setting, you'll most often be working in a radiology department and have that radiologist reading some of those films for you. But there are also, I mentioned the C-arm. The C-arm is going to produce images like the hysterosalpingogram here, where we actually put a tenaculum on the cervix and inject a water-based contrast, and you can see the uterine cavity fill and coat with that contrast and hopefully see it go into and out of the fallopian tubes. And you can see that this is obviously not a normal uterine cavity, and it's a divided cavity. But sometimes we also involve, imagery like MRIs and CT scans to try to get a better understanding of what's going on with that uterus. And you'll see in the chart here the multitude of abnormalities, Mullerian abnormalities, changes to the shape of the uterus that can contribute everything from being born with, half of a uterus to different, septums, or the arcuate uterus where it impinges upon the uterine cavity. And we know that these abnormalities occur during the development of the uterus. You can see that initially that uterus comes from two tubes, which comes together. That inner septum should resolve, creating one cavity and two tubes coming off of the top for our fallopian tubes. But as you could see, oftentimes that is not a complete developmental process, and so we do have women that are born with these other abnormalities. The renal system develops along the same lines and at the same time as the reproductive system. So when we see these abnormalities, then we're often going to enlist the assistance of the urologist. And they're going to help us look at that, the renal system, the urinary system. Sometimes these ladies will also have a horseshoe kidney. They'll be missing a kidney. They'll be missing a ureter. So when we see that uterine abnormality, then we're going to get other people, other specialists, again, involved to see if they have other abnormalities that need to be treated, or they at least need to know about. So in this case, our patient, we're saying, was found to have a septate uterus. So a divided uterine cavity, which is a very common finding with with recurrent pregnancy loss. Can people have normal babies with this? Absolutely, but it certainly increases their risk of recurrent pregnancy loss. And so when we find that, typically we're going to recommend resolving that septum or taking that septum out. Many gynecologists will perform this procedure. Some are not comfortable performing the procedure. It is typically done hysteroscopically, and you can see the hysteroscope going in. Usually you are guided from above, so the risk of treating a septum really comes into not being too aggressive. You want to take as much of that septum out of that cavity and open that cavity up as normally as you can, but you don't want to go through the top of the uterus because you're doing this hysteroscopically, and so you're using actually kind of a hot wire like instrument going in and cutting into that septum so that eventually you can see that it's gone. And as you cut into it, so you don't cut it out, you actually cut into it, and as you do that, just making sure that you don't go through the top of the uterus. This sometimes incorporates radiology, actually. I was trained to do these under ultrasound guidance, and so we would actually have someone doing an ultrasound on top of the pelvis while we were operating below to look at the depth and how deeply we were cutting into that septum. Other people do this with hysteroscopy and laparoscopy at the same time to ensure that they're not too aggressive. So, septum was treated, patient conceived on her own. She received some progesterone support from her REI, and then she was returned to her OBGYN at 9 weeks of gestation for continued follow-up and delivery. So just an example of how many specialists, and I apologize that apparently this program did not coordinate with my previous program and knock some of those letters off, but you can see how many specialists were actually involved. Yes, she was referred to the reproductive endocrinologist, and yes, you know, she may say, hey, my fertility specialist helped me, you know, to get pregnant and resolve this issue, but by no means did they do it on their own. It certainly took a team. So another example, Diana is a 27-year-old G0 female who's been trying to conceive with her partner John for 2 years. She describes her menses as irregular. She's actually skipped a period for 3 months. She was very excited, thought she was pregnant. Did pregnancy test, unfortunately, they were negative. So then she's wondering what's wrong. Her best friend convinced her to go to see her gynecologist. At her gynecologist, they discovered that she had polycystic ovarian syndrome. So ovulatory, irregular and ovulatory periods combined with excessive androgens and polycystic appearing ovaries on ultrasound. And the recommendation was made in order to assist her in ovulating that they treat her with medications. So medications that can be used are sometimes administered by the gynecologist in this case. Some gynecologists are not comfortable administering these medications because sometimes it requires closer monitoring. And, you know, just a note, people often associate IVF with high order multiples and with having multiple pregnancies. And we typically now see that more with ovulation induction because with IVF, we're good enough at this point that we're only putting one embryo back. So most of the time you're just having one baby. With ovulation induction, you have much less control. And so ovulation induction can be practiced by a gynecologist. Many do not want to monitor it closely and get involved. Certainly, ovulation induction can involve medications like Clomid that most of us have heard of. Letrozole, becoming more common as well, has fewer side effects. They work through different mechanisms to increase that FSH that is released and can stimulate the creation of follicles and therefore eggs, and to result in ovulation ultimately. So unfortunately, this patient did not conceive on Clomid and letrozole and was referred to the reproductive endocrinologist at that point. Typically, if just giving them medicine at first doesn't work, by the time they get to the infertility specialist, we're going to look at a more detailed picture. So we're going to look at ovarian reserve testing, we're going to evaluate the fallopian tubes, and we want to look at the male factor evaluation. because we know there may be bigger underlying problems. So in looking at the evaluation of the fallopian tubes, again, this may involve a radiologist. And this is showing more views of a hysterosalpingogram, so that injection of that contrast. That center picture is what you hope to see. The filling of that normal appearing cavity, that contrast going into and out of the fallopian tubes on both sides. That upper picture on what would be your left would be more of what we would see with proximal tubal occlusion, no contrast, and then here on the right, hydrosalpinx or distally occluded tubes that can accumulate fluids. And of course, neither the proximal tubal occlusion nor the hydrosalpinx typically are going to result in a pregnancy. So both issues that would need to be treated. In this case, our patient was happy to find out that she had a normal cavity and normal fallopian tubes. Her partner did undergo male factor workup, and it was also found to be normal. And so the suggestion was ovulation injection and intrauterine insemination. So being a little more aggressive with that medication, stimulating that ovulation, and then putting sperm closer to where it needs to be to do the job. After she came back for her ultrasound and 2 gestational sacs, 2 yolk sacs on ultrasound. So typically, most reproductive endocrinologists are going to see patients at about 6 weeks and about 9 weeks, and then refer back to their OBGYNs at that point. So 6-week scan, everything again looks wonderful. Everybody's excited. We did it. Comes back for that next scan, and the couple is still very excited, and the reproductive endocrinologist is not smiling anymore, because we now see that beyond our control and beyond what we could see at that initial scan, we've got more babies than we initially prayed and asked for. There again, we are not in ultimate, control. We see that one of those sacs is in fact holding 2 babies. We know that this can occur, cleavage can occur at different times, and this is absolutely a higher risk pregnancy. And at this point, we get maternal fetal medicine involved. So that's when you make the phone call, and they're going to go see the maternal fetal medicine specialist for anything that is more complicated. So when we see those scary things on those initial ultrasounds, or if we know about, if they've had issues in the past with children with birth defects, if they have major maternal issues, we will consult ahead of time with the maternal fetal medicine specialist, just so that they know them ahead of time. They can talk to them about risks in later pregnancy, but getting them involved. In this case, they're going to be able to monitor them more closely to know exactly what they're dealing with. Are those, babies potentially conjoined? Are they, at what point would they have divided, and what they need to do to protect them and do their best to keep them safe and their mom safe throughout pregnancy. So again, in the grand scheme of things, a pretty simple case, but still involving a much broader team than just the fertility specialist. Another vignette, Olivia is a single 25-year-old G0 female. She was recently diagnosed with breast cancer. She meets her oncologist. She's overwhelmed by her diagnosis, of course, concerned about facing this illness, possibly even death. Her oncologist suggests treatment as soon as possible. She asks if Olivia would like to consider fertility preservation. We love the oncologists that remember to ask that. She cannot even think of a future right now, but the oncology staff calls the local REI, and typically most are going to work these patients in. We did every time. If my staff, we would stay late, we would come in early, we would get these patients in the door if they were willing to come, because so often they're not willing to come. They are so overwhelmed by this surprise diagnosis and, are most worried about if they're going to survive the illness, and, the financial and emotional stress that it's going to bring upon them and their families, that they can't even think beyond that. And I again applaud those oncologists that say, take a second, think about this. We're getting better and better at treating this, and think about, the life on the other side of this diagnosis, and trying to encourage those patients to at least think about it. So in this case, Olivia comes. It's discussed, just a quick highlight to some of the multitudes of types of cancer that, you may want to think about fertility preservation here. When she comes, she decides to undergo fertility preservation, and this has to be very carefully coordinated, of course, with her oncologist. So you are looking at timing because, again, they recommended that she undergo treatment as soon as possible. Oftentimes with fertility patients, you're waiting until they have their period, then you're checking their day threes, or you're getting that AMH or FSH, and then you're getting those values back, and then you're ordering meds and you're getting started. And in this case, you don't have that. You're trying to do an ultrasound, get what you can get as far as AMH and blood work, and get started as soon as you can to retrieve those eggs and not delay that patient in potentially life-saving treatment. You're also having to balance risk to that patient, because when we give them medications to grow those follicles in their ovaries and to grow their eggs, their estrogen levels also increase as we're going through that. And so you're trying to balance making as many follicles, because we know we don't get an egg from every follicle. We know not every egg is a good egg, not every egg is a baby maker. So balancing getting to as much as you can without putting that patient at greater risk. And so very much coordinated with the oncologist regarding the medications, the timing, the balance of creating those eggs. So she takes medicine, she undergoes a surgery, and those eggs are retrieved. Those eggs are then frozen. So there we begin to involve the embryologist. So they're going to freeze those eggs in hopes that she is one day able to come back, use those, together with the sperm of her partner or donated sperm to create a baby one day. So in this case, Olivia recovers well. She's healthy. She meets a wonderful man, Steve. They get married, and finally decide to try to have children. They try on their own, the old-fashioned way to begin with, but eventually don't conceive, and she goes to see her gynecologist. At that point, recognizing what the treatments that she went through in the past, the gynecologist, suggests that she have testing to look at her ovarian reserve, and finds that she does have premature ovarian failure, and she is referred back to the fertility specialist. So they talk about treatment options. There again, when you are trying to stimulate a patient to even prepare the uterus for implantation, you are looking at elevated estrogen levels and creating that lining in the uterus to an optimal point for implantation. And you've got a patient that has been diagnosed previously and treated with breast cancer. So talking about risks in this case, Olivia's 42-year-old G2P2 sister, Sarah, offers to carry for Olivia to reduce her exposures and her risk. So things now get even more complicated. So at this point, you've got a gestational carrier who is related but still has to undergo significant evaluation before they can even take on that, that pregnancy. So it is recommended and in some cases required. So there are FDA requirements. There are also the American Society for Reproductive Medicine recommendations that the patients undergo pretty stringent screening before they can be a gestational carrier. There are also stringent rules about who can be offered a gestational carrier, just so you know. And that also involves a team getting involved to decide, there are those women out there that just don't want to be pregnant. It's inconvenient for sure for everyone to some degree, but they would prefer to have a gestational carrier, and that is certainly not encouraged and is frowned upon. And so screening, in this case, certainly this patient would be at risk with the stimulation to get her pregnant. Her sister is willing to do it, so it's an optimal situation, but that sister then has to be screened. She and her husband will be recommended for counseling. They undergo questioning. Why are they doing this? Are they being paid a certain amount of money? Are they prepared for if things don't go well? A multitude of issues. She needs to undergo screening by internal medicine and family practice. She is 42 years of age. You have to think of, greater difficulties in pregnancies at her age. Radiology, looking to make sure that she has an appropriate uterus to carry. She may have 5-centimeter fibroid inside her cavity that would certainly need to be removed before you would sacrifice those frozen eggs into that cavity and maternal fetal medicine. So she passes all the tests, and she goes back to the reproductive endocrinologist. They discuss with the couple that he is going to be screened. So we have frozen eggs. He has to be tested. So the original patient's husband has to be tested and to look at his sperm. The eggs are then thawed and inseminated with his sperm. So that involves the embryologist and undergoing ICSI. So intracytoplasmic sperm injection, where they actually take that sperm and put it inside the egg. They create embryos. In the meantime, the sister is being stimulated to create a normal uterine lining. And when that is optimal, those embryos are then placed inside the uterus. So typically, gestational carrier, you're going to place one embryo. And that process of embryo transfer looks much like an intrauterine insemination. It's done under ultrasound guidance to ensure that those embryos are placed in the right aspect of the uterus. So this is going to involve the REI. She will then be, of course, sent back to her OBGYN eventually, and in this case, the maternal fetal medicine. So much more complicated case involving a much larger team. But again, the REI is kind of just in the middle of it. Finally, Jenny is a 30-year-old G0 female who's been trying to conceive with her husband, Tom, for 2 years. Her OBGYN refers her to the REI for evaluation and treatment. They recommend basic infertility testing. So ovarian reserve testing, uterine evaluation, tubal evaluation, male factor evaluation. In this case, he has no sperm. So typically that original semen analysis is going to be done in the REI's office. We typically have labs to monitor blood and sperm in our offices because our patients are having to be monitored so closely and so frequently. But when we discover that there is no sperm there, then he's going to be referred to a urologist. It's interesting because as REIs, we actually train as obstetrician gynecologists, but you have kind of male patients too. And so you are treating that, couple as a whole. And so you have a lot of conversations with men about, how sperm are produced and all of those basic things. Most of us don't typically physically examine men, and we send them to a urologist for that actual scrotal evaluation, testicular evaluation. And in this case, this patient, we discussed that, there are different reasons that there's no sperm. It could be that he's not producing sperm. It could be that he's producing sperm and the sperm are not actually being ejaculated, and the urologist can help to find out more. So he is referred to the urologist, and they're going to do an exam. They actually found in this case that he had congenital bilateral absence of the vas deferens. So I know most of us here, again, we're trained and focused on girl parts. So just a quick reminder of the boy parts, and the testicles actually producing the sperm stored in the seminal vesicles, travels through the vas deferens, and then can be ejaculated. And so if they're lacking that vas deferens, then basically, they're missing the martabus. They're left there at the testicle, and they can't get to where they need to go. What could cause this? He hadn't had any surgeries. Why could this be happening to me? And one of the very frequent causes of this is that it can be related to cystic fibrosis. And you can either be a full patient fully affected by cystic fibrosis, you can be a carrier of cystic fibrosis. So anytime this is found in a patient, it is recommended that he sees a geneticist and that his partner sees a geneticist, because then not only are we going to worry about him being a carrier, we're also going to worry about then what happens if his wife is also a carrier, and the bigger problems that may result in. So referring to a geneticist, they're going to both undergo testing. In this case, they identified that they were both carriers of cystic fibrosis. Cystic fibrosis is one of those diseases, of course, that some patients, again, have all of the symptoms. Others have very limited symptoms. The geneticist is going to speak back with the REI, and they are then going to discuss the option of pre-implantation genetic diagnosis. So PGD, looking at testing embryos for the presence of specific abnormalities, can, of course, be controversial, as many things right now in fertility treatment are. But there are a number of diseases that can be identified and eliminated in the offspring. Certainly something that should be discussed with patients, in my opinion, should be offered to them, and then they can make decisions about what they do. Interestingly enough, there are some patients that would not want to proceed with PGD, that they will undergo IVF, but they don't want to proceed with PGD. There are some patients that intentionally, and I never was faced with this situation, but had other colleagues that told me that especially in some societies, in the Deaf Society, that they sometimes are very proud of that in some cases, and they actually want to ensure that their children have the ability to inherit those things. And so, as a physician, we're often so focused on fixing things that's hard to understand, but a lot, again, of controversy surrounding this option and this treatment. With PGD, the embryos are created, and then biopsies are taken of the embryo to determine which ones are carriers, which ones are actually affected, and which ones are normal and not affected. And so again, this requires a lot of coordination between the labs and the geneticist at looking at those things. It requires coordination with the embryologist, because you are trying to pick the most healthy embryo. So not every embryo that you create is going to be a good quality embryo. So you're having to then sit down with the patient and talk about, this is how many eggs you had, this is how many fertilized, this is how many actually continue to grow into blastocysts, and were able to be biopsied. And then these are the ones that are considered carriers or not affected at all, and these are your healthiest embryos, and to try to pick the ones that kind of all match up to put back. So a lot of coordination required in that case. In order to get to that point, remember, we had no sperm. So the urologist has to be called in, and typically he's going to go to the center where the IVF is being conducted to retrieve the sperm. And this can be retrieved either through epididymal aspiration in some patients. Testicular biopsy is required in other patients. Those procedures are typically conducted by the urologist, coordinated together with the preparation of creating eggs. So woman is undergoing the creation of the eggs and the stimulation of the ovaries. The urologist is being called in to retrieve the sperm. The embryologist is then called in to take the sperm and place it inside the egg with intracytoplasmic sperm injection. They're going to grow those embryos out. They're then going to biopsy that trophectoderm. So, patients will often say, well, is my baby going to be missing an arm or a leg? Or, you're taking a cell from this little blastocyst. But these are kind of extra cells, but they do provide that genetic information that can be tested. So it's not typically harmful to those blastocysts and certainly not to those future children. They're able to send that information off. So those embryos are then frozen. They send that information off, and we await those results of the quality of the embryos that were actually able to be frozen and which ones are in which genetic state. When we get that information back and the couple is ready to proceed, then we proceed with stimulating the uterus, monitoring to ensure that that nice trilaminar lining is available for the placement of those embryos. They're again selecting those embryos. Which ones are we going to thaw to put back to try to create the healthiest family and the healthiest babies? Putting those embryos in, placing those, and then hopefully achieving a healthy pregnancy and referring back to the OBGYN. So again, significant team that is required to create these babies. Certainly, it takes a village. It takes way beyond a fertility specialist. I think it is a perfect example of how that team all works together to create hopefully a happy and healthy baby and a happy family. That's all. Hopefully I didn't lose you guys. Any questions? Yes.
So in terms of, that was really loud. So in terms of insurance for the referrals to REI, do you find that that's something that insurance will help with, or does this end up being more of an out-of-pocket cost for the patient?
Yeah, it is becoming more insured. It used to be predominantly cash pay. But we are seeing more and more, especially employers that are offering that. I know it used to be, Starbucks was a big one, and we would talk to patients about, because there would be stay-at-home moms that would go get a job at Starbucks to pay for their fertility treatment. So I would say that coverage is getting better. It's a little bit of a two-edged sword, as it always is in medicine, because they are very expensive technologies to offer. And so it's very difficult, and you'll see that there are very few small fertility practices anymore, just like in medicine in general. We talked about very few, solo practitioners, and the same goes for fertility. It's going more to a private equity business because you have to have that to be able to provide those services, that the embryology equipment, even just, the contrast to do the HSG procedure typically cost more than, in my patients that were insured, more than the insurance would pay for me to do the procedure at all. Just the contrast, not my time as a physician, not, the facility expenses, not the disposables. So like all medicine, it's becoming harder and harder for patients and for practitioners. Yes, ma'am.
You mentioned in your case of young breast cancer survival, first they try to conceive naturally. I wonder after chemotherapy you expect premature ovarian insufficiency and loss of menstrual cycle. Did she lose? Did she know what she can't? Why would she try naturally
Yeah.
if she already lost menstrual cycle?
They don't always. And so, so some of them will not use, depending upon what their treatment required, they will not always. I had, one or two other patients that come to mind immediately that they conceived on their own. So they had treatment, they had frozen eggs. We assumed that we would be seeing them for fertility treatment in the future, and they were actually able to conceive wonderfully on their own. So it depends upon the chemotherapy. It depends upon, the type of treatment that they received. There are also some physicians that will administer Lupron in hopes that it will help to suppress the action of the ovaries and possibly protect them. The studies supporting that are not strong, but in some cases, patients are willing to do that rather than nothing at all. So yes, it is possible sometimes that they can conceive on their own.
And I wonder, do you have any picture in mind, maybe local or general, which chemotherapies or targeted therapies help to preserve the fertility? We know what cyclophosphamide and cisplatin are the most toxic for ovarian function. But if you look at novel therapies like CDK inhibitors, is there any knowledge at all about how it's affect ovarian function?
There probably is some. I would say that the most of the fertility specialists are not going to be as aware of the latest treatments that are always being used for all of the multitudes, of types of cancer. So that they're going to, there again, have to work closely with the oncologist to look at what that risk is, because the oncologists are going to be much more focused on those medications and what the latest thing is that's out and most hopeful or most helpful, and and its side effects. They're definitely going to be more knowledgeable about that than the fertility specialists. So we definitely have to work closely with them on that and knowing what to expect and how to predict that risk for the patients. Other questions? All right, thanks for having me.